probably the central challenge of the next decade in trying to solve the issue of health for Americans. And it involves, I think, some very interesting challenges on both the right and the left. The right has to decide that some aspects of the working poor has to involve transfer of finances. That to ask people in the lowest paying jobs to bear the full burden of their health insurance is just irrational. It's not going to happen. And so you've got to decide, is having them covered worth some kind of transfer? The president's proposed, for example, a fairly substantial tax credit, but it only covers part of the problem. The second question you have to ask, and I think this goes back and forth for a second, on the left, people have to decide, are you really willing to allow individuals to have control? I mean, I'm very opposed to a single payer system, but I'm actually in favor of a 300 million payer system. Because one of my conclusions in the last 6 years and founding the Center for Health Transformation and looking at the whole system is, unless you have 100% coverage, you can't have the right preventive care, and you can't have a rational system, because the cost shifts are so irrational and create second-order problems. So if you start with the idea, our vision is going to be everybody in America is in the system, it leads you pretty rapidly, I think, to 3 or 4 big, from my view at least, 3 or 4 big decisions that'll be could be a very creative dialogue. The first is, I would actually start looking at how to voucherize Medicaid as it relates to the working poor. You have a different challenge with Americans who have disabilities or with seniors in very long-term care. But if you start looking at the working poor, when we invented food stamps, we did not invent government-run grocery stores. Right. And in a way, Medicaid may have been misdesigned. So if I could find a way to bring everybody on Medicaid who's part of a relatively healthy population, again, distinguishing disabilities, which is a fascinating and different challenge, and long-term care from that issue, I think that starts to help change the whole thing and starts to eliminate health disparities, because one of the reasons you get health disparities is Medicaid pays so badly that doctors, in fact, underserve that community for reasons that are totally legitimate doctor by doctor. The second thing I think you've got to do, whether you go with the president's version of cross-state boundary purchasing or you find some other way to do it, you've got to create very large risk pools for individual purchasers. It is, and let me be clear about this. And again, I know I risk sounding not quite as right-wing as I should to fit the billing. It is perfectly rational for an individual insurance company to design a strategy of cherry picking. We have invented a system of health insurance where the highest profit margin is insuring people who don't need it. Now, that's perfectly rational for the individual company. It is utterly irrational for the society. And so part of what you have to look at is, and we have Ron Bachman, who's joining us at the center, is working on a program to look at, can we build an actuarial model where we actually have very large risk pools made up of individual purchasers, but where you begin to eliminate the cherry-picking phase. And there are a couple of interesting ways to do that. And I think that's a topic that the Congress ought to be taking up and holding hearings on, to look at which mechanism would minimize cherry-picking. And let the companies all come in and explain how they would do it as a core model of American healthcare. That's an individual corporation strategy. That's not a public policy strategy. The other thing I want to say that will sound unconservative, except I think it fits exactly welfare reform in our proposal of 1996. We said in welfare reform that it was actually bad and destructive to have people sitting, waiting for the next check, and not acquiring the habit of work and the habit of learning and the habit of striving. And we very dramatically reformed welfare, actually towards a model that was created in New York City by America Works, a company that was made up of former social workers who actually went out and helped people find jobs, helped the hardcore unemployed get into work and have the habit of going to work. Most people agree that broadly defined welfare reform has really worked. It's been about 60% of people who are on welfare went to work or went to school. Most of them who did now say in retrospect they wish they'd done it earlier. And so there's a model here that the conservatives will all applaud. But my point to conservatives is it's a model of responsibility. Well, if I see somebody who's earning over $50,000 a year who has made the calculated decision not to buy health insurance, I'm looking at somebody who is absolutely as irresponsible as anybody who was ever on welfare. Because what they've said is, A, I'm gambling that I won't get sick, and B, I'm gambling if I do get sick, I can cheat all my neighbors. Now, when you talk to hospitals, a very significant part of their non-collectibles are people who have money, but who've calculated that it's not worth the cost to collect it. And so I'm actually in favor of finding a way to say, if you're above whatever the appropriate income level is, you ought to have you ought to either have health insurance or you ought to post a bond. But we have no right in this society to have a free rider approach, if you're well off economically, to say we'll cheat our neighbors. One last comment. We should really look at tax equalization across the whole system, because the way you're going to migrate to an individual purchase of health insurance is to have the same tax deductibility, whether you buy it individually, you buy it as a small company, you buy it as a large corporation, and to have a very robust tax credit for the working poor, and then a voucher for Medicaid.
Thank you very much. One concept is that